Songku Lushra, and I apologize for the pronunciation of your name, but talking on the ocular standpoint.
Okay, thank you so much, Professor Graham. So, for Professor Miller, I'm going to go for the immunosuppressive medication for the ocular diseases in the view of ophthalmologists. Okay, so I have no relevant financial disclosure. Okay, mainstay treatment of the I'm going to say non-infectious uveitis is yes, it's steroid for sure. And what is the corticosteroid use? Is the best agent to control the inflammation as quick as possible. This is really the message. Some say that the immunosuppressive is more powerful. It's not. The most powerful is the corticosteroid, that you can control the inflammation as soon as you can. And corticosteroids are the mainstay treatment of uveitis in some of these. Therapy of the active inflammation in the eye, prevent treatment complications such as macular edema, reduction of inflammatory infiltration in the back of the eye, including retina, choroid, and optic nerve. And all you know that steroids have a lot of side effects. It can cause systemic side effects, increase of infection, fluid edema, mood change, insomnia, hypertension, and a lot more that you already know. In ocular diseases, three main side effects is intraocular pressure that can lead to glaucoma, in the cataract, and ptosis. The goal of treatment, I'm going to start with the goal of treatment. The goal of treatment of the uveitis is not get rid of everything from the eye. The goal is to effectively control inflammation and reduce risk of vision loss from structural and functional complications. So, the benefit of treatment overweight the risk is that you prescribe the treatment. Always think about this one, about the risk and benefit when you use it. Okay, it's not always indicated in the chronic flare because we know it's just the breakdown of ocular barrier. It may be not appropriate to treat the pigmented cell in the full heterochromic idiopsychitis or in the viral infection, and in the may not appropriate to treat in the papillary without macular edema with the patient have 20/20 perfect vision. And also in some cases of toxoplasmic lesion that far periphery and don't cause any effect to the vision. Okay, this is the very nice review that put all the expert panelists together and guideline to use of the of the corticosteroid and in the uveitis, and you can see it and you can read it. Okay, I just want to remind you that uveitis is a variety of diseases that share common characteristics with its intraocular inflammation. It's not just one disease, it's the group of diseases. And the most of non-infectious uveitis diseases are chronic in nature. What does it mean? It means that it's chronic in nature. There is something to control it, right? And somehow uveitis disease is not only for the eye. You might need to looking for the associated systemic diseases. You might need to work with your rheumatologist and medical internist to take care of the patient, not just the eye. And law of immunosuppressive agent, we today going to talk is when you have the law to use it and how to use it. Again, always thinking about the risk and benefit for the patient. Okay, in the common indications for immunosuppressive therapy for the uveitis is visual thickening, intraocular inflammation, inadequate response to the corticosteroid treatment, chronic corticosteroid dependent that need more than 7.5 milligram of prednisolone a day, or conventionally 10 milligram. Okay, corticosteroid contraindication that they have systemic or intolerant to it. And this is the treatment strategy that was proposed for very long periods of time. It's the step-ladder approach. So you start with the low one and you're stepping up a little bit when you cannot control the diseases. Okay? But now, the evolution drug used in the non-infectious uveitis have a little bit changed. Let's say most of uveitis patients is chronic in nature. You see, chronic phase can turn, active phase diseases can turn to chronic phase. And in the acute phase, what we use for it, absolutely, is the steroid. The frequent and high dose of topical and systemic steroid in the proper route can help in the acute phase of it. And after you controlling inflammation, you need to slightly taping down for the steroid, and some people may need long-term steroid use to control inflammation. But please notice that every patient is different. Taping schedule for every patient may be not suitable for every patient. I mean, taping schedule, fixed schedule for it, okay? And some of these patients going to be turned chronic, okay? And that maybe need anything else to control the inflammation. That is the immunosuppressive come to be a role, okay? Let's say somehow some diseases have a trend that we use immunosuppressive in the early. Why? Is it too aggressive? No, because we want to use it in the acute phase to stop it, to turn to be chronic. This is important. So today, I'm going to talk about the term that called therapeutic opportunity. What is therapeutic opportunity? It's about the prognosis of diseases, it's about the early detection, early recognition, it's about early and adequate action and treatment of the uveitis patient. Okay? So the classic example is glaucoma patient. Everyone knows glaucoma. If patient come like this, there's no way to get the vision back. Patient may have 20/20 with the tubular vision, no way to get the visual field back, right? Same way with the uveitis, okay? I don't say that we need immunosuppressive in every case of uveitis. We need to know the nature of the diseases. Not every uveitis patient that you need the immunosuppressive, okay? This is the very well studied by a group of Dr. Foster that list of the absolute indication, suggestion of the absolute indication of the immunosuppressive use and the relative indication of the immunosuppressive use in the early treatment of the uveitis. Okay, it's maybe a little bit too small for you to see, but let's say most of them is ocular patient. If you deal with the ocular patient, you're gonna know that sometimes one immunosuppressive is not enough. Sometimes 2 or 3 is not enough to control the inflammation, especially in the eye, because all of us know that eye is the immune privilege. Somehow, it's act like it have the different response to the immunosuppressive. VKH, SO, and ANCA-associated vasculitis, and also peripheral ulcerative colitis. Okay, let's get the example. The classic treatment, the classic state of the VKH or Wolff Korean-Harada syndrome, which is very common here in Thailand and in Asia. The first stage is the bottom state. Patient may have the fever, flu-like symptom. They may go to the acute uveitis state and go to the convalescent state and turn chronic and recurrent and chronic recurrent state. Okay? So I'm going to say acute uveitis state is benign. The truly malignant is the convalescent state. If you treat it, it's benign like the baby monster. You might not agree with me. I will show you later. You might not agree with me. But when it turns convalescent, it's going to be the big monster, and maybe sometimes you cannot control it, and sometimes it's impossible to control it. I will show you. This is the classic VKH. Now we have multimodality to diagnose it. You can have the very nice OCT that show the subretinal fluid with classic septate lesion underneath it. You might see the classic starry night, it looks nice, right? Like the sunny sky, the Milky Way in the everywhere. You can see the thickness of choroid by the EDI or the Swepsol OCT. And the ICG that really help, because now we know that the VKH is the stromal choroid diseases. It means it mainly attacking choroid, and everything that affects the retina is come later. So in ICG, that clearly show that it have multiple hypofluorescent dark spots. That means the inflammatory cells, that means the activity of the diseases, and recently, the OCT angiography. The angiography without dye show the dark spot in the choriocapillary flap as well. Okay, let's go to the case. This is our case in our hospital. Everybody knows it's a VKH, is very active. This is edema, a lot of fluid. You see the choroid is super thick there. Okay? Absolutely. The mainstay treatment, steroid. We give a bigger dose of steroid with the intravitreal methylprednisolone. You see the retina come back nicely. The VA come back, vision come back. But if you look at the OCT angiography, you see normal corneal thickness, but in the choriocapillary valve, you can see it's a lot of multiple dark spots that called foveal, and this correlate with the ICG. It means that something's still going on. If you live with this is going to be turned to be the chronic phase, it's going to turn to be convalescent phase, and that the malignant diseases. Okay, so Dr. Carl Harbot and his group published very nice paper about we don't want to see this again. We don't want to see the sunset goal from that again. How we have to attack it nicely, attack it rapidly and enough in the early stage. In the another word, I'm going to show you it again sometime. In the proximal state, it's like the wildfire that's just growing up. You have the fever, you have flu-like symptom, and you have a big fire going up when you have the acute uveitis state. You have subretinal fluid, vision very drop down in that state. And also in chronic, in convalescent state, in the malignant you say, it's nothing left that you can treat. It's still something left, but it's nothing much left. So we have to attack it rapidly. And in the chronic recurrent, it off and on and continue to damage your eyes. Okay? That is the example of the VKS disease. Another disease that's very tough is the patient. Patient can come with a hypopenia that can mobile when you move the head. Patient can be very bad. This is our case, nothing much to do. It's the occlusive vasculitis. All of the retina is atrophy. Vision is very bad. I think, I cannot remember, it may be counting finger or something. And now, we did a study on the OCTA in patient. We include the patient about 32 eyes and perform comparison of the ICG, FFA, and OCT angiography and with the OCT as well. Okay, and we compare it together. This is I would a little bit review about OCTA. The OCTA detects the decorrelation of the tissue on the retina. It means that the stationary tissue, the tissue that's stable, that not move, is going to have very stable signal. But the tissue is moved, it's going to have decorrelation. So the most thing that moves in the retina is the red blood cells in the blood vessel. That's how we can detect the vessel in the retina. And with the advantage of the OCT angiography, because of we acquire a lot of data for the A and B scan OCT, and we compare it. So we can differentiate between superficial capillary plexus and deep capillary plexus, that which is the inner retinal circulation. And you cannot separate it if you use the FA angiography, because it comes together and you cannot differentiate it out. If you look at the picture, this is one of the picture. On the left-hand side is the FA, is a CSLO. You can see the fast zone of the FFA. It's like that. It looks very normal. This patient has 20/20 vision. In the superficial capillary plexus, you see it's not pretty the same. But if you look down into the deep capillary plexus, they have a lot of foveal area in the deep capillary plexus. We might think this is the pathogenesis of why patients have the central visual loss in patient. And if you look at here in the red area, you have to integrate it with multimodality. We think it's the foveal, but it's not. It's the CME, and it has a segmental artifact. I might not have time to get through all these artifacts. But if you look at the green area, that's the selective loss of the deep capillary plexus. This may be explained why patients have visual loss in patient. And the deep capillary plexus trend to be watershed zone. I mean, the blood is not enough compared to the superficial capillary plexus that supply the retina. Okay, so we don't want this one. So we have to attack it again. We call it therapeutic opportunity. It's the opportunity that you can save patient vision. So please don't undertreat it. And I have to say, don't overtreat it as well. Okay, it's very important to be don't undertreat and don't overtreat. That is the nice of uveitis. Amen. Okay, for the take-home message, uveitis is not a single disease. It's a group of diseases that share common characteristics. I don't say not every cases of uveitis need immunosuppressive, but in some cases like Behçet, that you know the nature of the disease that require immunosuppressive. I mean the ocular Behçet that have vasculitis, they need immunosuppressive. It's essential to use it. Okay? Gold treatment is the lowest effective dose to control inflammation. We don't use steroid for the whole of charm. We want to use the lowest effective dose to control it. And remember, least overwhelm, benefit low. Cells is not always be active inflammation. You have to differentiate between red cell, white blood cell, pigment cells. Okay? No need to get rid of every cell. Common pitfall, as I say. Think about it, over and under. Not just for treatment, but also for the investigation and diagnosis. Again, I very carefully pick this slide up because today I talk about aggressively use of immunosuppressive and aggressively treat of the patient. But remember, both differential diagnosis of the uveitis is infectious, 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 non-infectious, and muscular. Almost always treat infection. If you have any doubt, always treat as infection. This is the really important message before you go with the therapeutic opportunity. Okay, the last slide. Corticosteroid is the mainstay treatment of non-infectious uveitis, not the immunosuppressive. And remember, therapeutic opportunity. You might have a chance to save the people's eye. Treat your patient, not only patient eye. A lot of uveitis is the systemic disease that you have to work with Professor Manati, with our team to take care of the patient. All patients are individually. No curtain schedule for tapping. No fixed regimen for everybody. And if you know the nature of diseases and pathogenesis, you might choose the immunosuppressive properly. Let's say in the VKS, the pathogenesis is most likely for the T cell. So the most proper is cyclosporine or tacrolimus. The Behçet, they very tough. I mean, whatever you choose did not really work. But by the evidence, the infliximab or the TNF inhibitor is really work for Behçet. Okay? Know your patients, know yourself, and always deliver a plan.